So we respond to the call, we get to scene and assess the patient. If they are showing stroke-like symptoms, we immediately load them into the ambulance.
We're going to be on our way to the hospital. I want you to do me a favor, Earl. Can you lift your arms up for me?
When looking for a proper facility to transport to, we look for at least the primary stroke facility, which can provide us with 24-hour CAT scan, the ability to administer the clot-busting drug, and the ability to have telestroke.
Manchester Memorial Hospital and Rockville General Hospital both got primary stroke center certifications by the Joint Commission. That means that we now have standards that we have to provide, care for patients, and we have the ability to care for patients who have acute ischemic stroke symptoms.
We call the hospital en route to notify them we have a possible stroke patient.
Manchester's on, go ahead please.
Manchester 512 Alpha 2, we're about 2 minutes
out with a 5'7" male.
Sign is on the monitor at 83 with an O27 94%. I am calling a stroke alert.
You're 3 minutes out, we'll call the stroke alert.
We'll get a patch from the ambulance crew that will come through the radio, and then we'll have a notification that will go out to the entire hospital so that the ED stroke team, as well as the lab and CAT scan and radiology, will be aware that we have X amount of time before this patient's coming to the hospital so that we can be prepared. Once the patient arrives in the ER, they'll stop at triage really quick. Triage will do a quick assessment. The provider will see the patient, do a quick assessment, and then we'll get them immediately to CAT scan. Good. We'll see you as soon as you get back.
The patient is then brought to the CAT scan table.
They'll get the CAT scan performed, and we're doing the CAT scan to rule out other causes for stroke-like symptoms.
After a stroke notification occurs, we're brought the images as soon as they're available off the scanner. We quickly review the images for any signs of large stroke or any intracranial hemorrhage or other reasons why a possible clot-busting agent couldn't be administered, or alternative causes for stroke-like symptoms in a patient.
Once that patient then has their CAT scan done, they will come back to the ER into a room. They'll be reevaluated again, and a determination will be made if they're a candidate for the thrombolytic medication to treat acute ischemic strokes.
When a patient comes into ECHN with stroke-like symptoms, it can be a very scary time for them. I check their blood sugar to make sure that they're not hypoglycemic. I start an IV. We assist the doctor with any testing he needs done.
During that time, we will put out a call to the neurologist who's at Yale New Haven Hospital, and we'll do a teleneurology consult.
Mr. Anderson, I'm Dr. Schindler. I'm one of the neurologists. I'm working with Dr. Castellone. I'm from Yale New Haven Hospital. I'm going to be helping Dr. Castellone evaluate you since there are some concerns that you may be having a stroke.
The neurologist can actually do an exam on the patient with a camera on top of the computer and have them do certain tasks of the exam. Then a determination is made on what the treatment is going to be for that patient with the neurologist. They're available 24 hours a day, 7 days a week for this acute care.
Dr. Castellone, I would agree with your radiologist. I don't see any evidence of a previous stroke. There's no hemorrhage. You know, his CAT scan looks like there's no acute abnormality, so I would recommend that we, consider giving lytic.
Sure. Yeah, we've got the TPA here, so we'll go ahead and we'll mix it up and we'll get him the bolus and the infusion, and we'll get him admitted and taken care of.
After they receive TPA for stroke, our patients typically come up to the ICU, and they're closely monitored with a strict protocol, including vital signs and most especially their neuro status. The protocol is something that both the ED and the ICU nurses are both trained to provide. It includes the NIH SS scale, which is the standard scale that we use for both physicians and for nursing. The goal is to treat the patient quickly. As we say, the time is your brain. So the quicker that you treat the patient, the more likely the patient is going to turn around and return back to their normal status, hopefully. It has been proven that if you have the family at the bedside, it does provide an environment that they actually heal better and heal quicker. They like to be reassured by their family. They like to wake up and see a familiar face next to them who knows their every need and knows things that they like and dislike. There's nothing better than seeing a patient who comes in with a stroke symptom and then gets the TPA and is able to respond back and communicate back to that family member. It's quite emotional for a lot of the family that are there and experience that, but as caregivers, that's what we strive for every day. Discharge is an exciting time. It's great to see a patient who comes in here needing critical care and then is able to either be wheeled. We even have patients who have walked out of the facility. Every member of the team is usually here, gives their goodbyes. They're actually part of our family. So it's a great time to walk them out and discharge them right out the front.